Now that we have had an overview of management of vertigo, let us be more specific. In the next few, not too few minutes, we will be discussing about the specific therapies of the different conditions that make patients present to the doctor with vertigo. As we said, the commonest is benign paroxysmal positional vertigo. What is it? BPPV patient would present with vertigo for a few seconds only on change of head position. It will start with pretty severe giddiness, and the patient will say that I get the giddiness only on getting up, lying down, turning towards the sides, and each episode of giddiness is for a few seconds only. It is diagnosed by the positional tests like the Dix-Hallpike test for posterior canal, as you are seeing in this video here, and by the tests for the lateral canal and the anterior canal. So these tests need to be done by the clinician in the clinic if ever the patient presents with the symptom of sudden onset of repeated attacks of giddiness that is occurring only on change of position. That means on lying down, getting up, picking up something from the ground or looking under the sofa, getting something from the upper shelf of the almirah, looking at the fan, trying to clean the ceiling, picking up something from the floor, turning to one side while in bed. So whenever the patient presents with a symptom like this, and if the patient specifically says that the giddiness is for a few seconds only, then all these different positional tests have to be done by the clinician. Now we are testing for positional vertigo in the right lateral canal. Now we are testing the left side lateral canal. When we are performing the tests for the lateral canal positional vertigo, then the head is turned towards one side horizontally with the head raised by about 15 to 20 degrees, as you see in the video here. While looking for lateral canal positional vertigo, the clinician has to look into the patient's eyes for any nystagmus beating horizontally either towards the floor or towards the ceiling. If the nystagmus is beating towards the floor on the side to which the head has been turned, it is a lateral canal geotropic nystagmus. Here, if the nystagmus is beating towards the floor, then it will be a left lateral canal geotropic nystagmus. But if the nystagmus was beating towards the ceiling, then it would be a agiotropic left lateral canal positional nystagmus. The same, of course, will be there for the right side also. That means when the head has been turned to the right side, if there is a horizontal nystagmus, not a rotatory nystagmus, just a horizontal nystagmus, if it is beating towards the floor, then it is a right lateral canal geotropic nystagmus, and if the nystagmus is beating towards the ceiling, then it is a right lateral canal agiotropic nystagmus. In lateral canal, the nystagmus will always be a horizontal nystagmus and never a rotatory nystagmus. A rotatory nystagmus indicates that there is a positional vertigo involving the posterior canals. While testing the anterior canal for positional vertigo, the clinician has to look into the patient's eyes for any downbeating nystagmus. That means nystagmus beating towards the foot of the patient. Specific therapy. For the posterior canal, we do the Epley's maneuver or the Simon's maneuver. We will show you now. For the lateral canal, we do the barbecue maneuver and the modified Guffoni's maneuver. And for the anterior canal, we do the Iacovini's maneuver. Epley's maneuver for the right posterior canal. How do we do it? Patient is made to sit like this with the head turned 45 degrees to one side, and the patient is made to lie down with the head 45 degrees to one side and 30 degrees below the horizontal, and the clinician looks into the eyes of the patient. If there is any rotatory nystagmus beating towards the floor, then it is a geotropic posterior canal BPPV, and if the nystagmus, rotatory nystagmus is beating towards the ceiling, then it is an agiotropic posterior canal BPPV. If this is done correctly, in 80 to 90% of the patients suffering from posterior canal BPPV, which is commonest, this will be completely cured. This is called the Epley's maneuver. Next, we come to the Simon's maneuver. In Simon's, we are showing you the Simon's maneuver for the right posterior canal. The patient lies down, is made to lie down like this, and it is found that the patient is having a rotatory nystagmus beating towards the floor. Then this is the movement that is done. Patient is suddenly made to lie down on the other side, now this time with the head looking downwards, the head bent downwards. So this is the Simon's maneuver for the right posterior canal. After this is done, the patient is made to sit up like this. Now we come to the disorders for the lateral canal. We will first show you the barbecue maneuver for the right lateral canal. When the test was done, the patient was found to have a lateral canal BPPV on the right side. So this is what we need to do now. The patient is made to lie down flat, then turn on the left side, 90 degrees on the left side. The head will be kept like this for 30 seconds. We tell the patient that you will be getting some amount of giddiness. After the giddiness settles down, then you count from 1 to 30. After that is done, then the patient is actually rotated like a barbecue. Then the patient is now made to lie on the stomach, that is completely prone. Again the same thing, patient is kept in this position for another 30 seconds. After the giddiness has died down, then the head is now moved to the right side, the entire body. In fact, you see, in this we have to move the entire body, and now the patient is lying down horizontally with the head turned on the right side, and then we make the patient lie down again looking towards the ceiling. So this is one complete 360 degrees movement. We make the patient move at 90 degrees, and at each step the patient has to wait for 30 seconds. So this is the complete barbecue maneuver. The other maneuver that is done for lateral canal is the Guffonis maneuver for the right lateral canal. The patient is made to sit up like this, and the patient is now made to lie down on the left side with the head in the horizontal plane like this on the left side. Since this is the right sided lateral canal BPPV, the patient is made to lie on the left side now, not on the right side. After keeping the head in this position for about 90 seconds, then we ask the patient whether everything is fine, and then we rotate the head like this to make the patient look towards the floor. We keep the head in this position for another 90 seconds and then make the patient sit up slowly. So this is the modified Guffonis maneuver for right lateral BPPV. The opposite thing is done for the left lateral canal BPPV. That means had it been on the left side, we would have made the patient lie down not on the left side but on the right side. That means for a right sided thing, we make the patient lie on the left side, and for the right sided BPPV, lateral canal BPPV, we make the patient lie on the left side. This is the Iokovinis maneuver for anterior canal. We make the patient lie down like this and see whether the patient is having any downbeating nystagmus. Then we slowly fold the head, that means in the neck, and then keep the head like this, and then at that position we keep the head for another 1 minute or so, with the head slightly more flexed than what is seen over here. That means the chin touches the sternum, and then we make the patient sit up. This is the complete echovenous maneuver for anterior canal BPPV. These are very easy to do, and any physician can definitely do these things very effectively and efficiently in their clinics. So none of these patients of positional vertigo ever needs any medical treatment at all, and this is all that is necessary. The next disease in our list is vestibular neuritis. What is vestibular neuritis? The patient of vestibular neuritis will present with sudden onset of acute vertigo without any ear or central nervous system related symptoms, and it starts today, it will continue for about 2 to 5 days if the patient is kept without treatment. Usually these patients are given some anti-vertigo drugs within a few hours, or some injection of prochlorperazine or something, and so the symptoms come down. So if you find a patient has come to you with severe onset of acute vertigo that has started a few days back, or has started today or yesterday, with severe head spinning, with nausea and vomiting, but there is no ear or central nervous system related issues, then and only then think about vestibular neuritis. In vestibular neuritis, there is no ear related symptoms, that means no blockage of the ears, deafness, buzzing sound, etc., or any central nervous system symptoms like diplopia, headache, weakness of the limbs, any sensory loss, nothing will be there, or any unconsciousness, nothing will be there. So a patient presenting with acute vertigo, sudden onset with severe nausea, vomiting, is in all probability vestibular neuritis. Had the patient been left untreated, then it would have continued for 2 to 5 days. So by definition, vestibular neuritis is any vertigo without any other symptom for 2 to 5 days. But today what happens is, most of these patients, after they get giddiness and nausea, vomiting, they will get injections of Stemetil and dimenhydrinate or this ondansetron, etc., and so the symptoms will come down. So that history has to be taken properly. Vestibular neuritis is diagnosed by the typical history as we discussed in details. Clinical tests would show a spontaneous nystagmus, and the head impulse test would be positive. When dealing with a suspected patient of vestibular neuritis, the clinician should always keep in mind that this patient could also be a patient of acute cerebellar or brainstem infarct, because these patients will also present with similar findings. Any patient of Wallenberg syndrome would present in a similar way with acute vertigo, and this has to be kept in mind. The only differentiation clinically is that if it is a central disorder, that means if it is a lateral medullary syndrome or Wallenberg syndrome, infarct in the cerebellum, then the head impulse test will not be positive. Usually the head impulse test is definitely negative if it is a case of cerebellar infarct. But in cases of lateral medullary syndrome, the head impulse test may or may not be positive depending upon the area involved. Usually it is negative, but it can also be positive. So this thing has to be kept in mind. The investigations that one may advise in such a patient is the video head impulse test, VNG, that is video nystagmography, cervical FEM and ocular FEM, and a pyotonodometry. Pyotonodometry would obviously be normal. Imaging studies are usually non-conclusive in such patients. In vestibular neuritis, imaging studies would be perfectly normal, and also in a case of acute cerebellar infarct, in the initial few hours, the imaging studies would not reveal anything much. It usually takes about 24 hours or more for any definite radiological evidence of infarction to show up in the radiological tests. Any MRI or any radiological studies would also show completely normal findings. The specific treatment for vestibular neuritis is steroids. Some people combine the steroids with antivirals like acyclovir, etc. But research shows that just steroids suffice. Since in the first 1 or 2 days there will be severe nausea, vomiting along with the giddiness, it is prudent to give some vestibular sedatives for 1 to 3 days at the most. Very rarely the patient will require continuation for 5 days, but even if a little bit of symptoms is present, after that the vestibular sedatives should not be given and only the steroids should be continued. Vestibular sedatives should under no circumstances be continued for more than 5 days. You see, it is in the first few days after the assault to the vestibular system that the vestibular compensatory mechanism actually is most effective. And so in this time, in the first few days, if we sedate the patient with these CNS depressant drugs and with these anti-vertigo drugs, all of which also are, say, if not all, at least most of them are CNS depressants, then the problem is we are reducing the sensory conflicts, and if the sensory conflicts get reduced, then the vestibular compensatory mechanism, which is the mainstay of treatment, will get jeopardized and the patient's restoration of balance will be improper. So we have to use the anti-vertigo drugs in these patients extremely judiciously and conservatively. The next disease that we would be discussing is migraine-related vertigo. It is a very common cause of vertigo that makes the patient present to the doctor with head spinning. The presentation is very typical. The patient of migraine-related vertigo or vertiginous migraine would come to the doctor presenting with recurrent episodes of vertigo of varying duration but without any ear or central nervous system related symptoms. There will be recurrent episodes. The difference between this and vestibular neuritis is that in vestibular neuritis there will be one episode, because recurrence of vestibular neuritis is very rare. In about only 1 to 2% cases of vestibular neuritis there is recurrence. But in vertiginous migraine, recurrence is the main issue on which the condition is diagnosed. So if the patient is presenting you for the first time, you would not know whether this is actually a vestibular neuritis or it is a first attack of vestibular migraine. If the thing keeps on repeating, then we would suspect retrospectively that it is vestibular migraine, and then we would start therapy for vestibular migraine. But if it does not recur at all, then we would know again retrospectively that what had happened was actually vestibular neuritis, because both in vestibular migraine as well as in vestibular neuritis there is usually no accompanying symptom related to the ear or to the central nervous system. Of course, in vestibular migraine some patients may have concomitant headaches along with the vertigo, but then that is not always. So the presenting feature in migraine-related vertigo is recurrent episodes of vertigo of varying duration. It can be anything between 5 minutes to 72 hours without any ear-related or central nervous system symptoms, except for rarely headaches along with the vertigo. There will be a past history of headaches, motion sickness, and a family history of migraine. So when these things are there, then we can suspect that possibly this is vestibular migraine. Unfortunately, there is no specific test for vestibular migraine, and so diagnosis is a little difficult. Specific therapy, vestibular migraine has got specific therapy, and the therapy consists of migraine prophylactic medication like topiramate, divalproex sodium, propranolol, drugs like amitriptyline, venlafaxine, etc. So a judicious combination has to be thought of considering the side effects of these drugs and which is suitable in which particular patient. Like if it is a lady in the reproductive age, we would not want to prescribe divalproex sodium. If there is a history of liver disease, we would not want to prescribe divalproic sodium. If the patient already has low blood pressure or a low pulse rate, we would not prescribe propranolol. If the patient is too thin, we would not want to prescribe topiramate, as topiramate is known to reduce weight. And moreover, whenever we are prescribing topiramate, we have to tell the patient that if there is excessive hair fall or if there is pain in the eyes or any blurring of vision, then the topiramate has to be stopped immediately. There are other choices are available also, like flunarizine is a pretty good drug for vestibular migraine. So any of these drugs can be given if we find that so it is not that we are out of choice. We have a lot of choice for prescribing the drugs for vestibular migraine. So it's basically a medical therapy only. And as and when there is an attack of giddiness due to migraine related vertigo, we give abortive medication. Abortive means medication, symptom relieving drugs which would abort the attack of giddiness. Like we give say usually 2 tablets of 50 milligrams of dimenhydrinate, and with it say ask the patient to suck 1 tablet of prochlorperazine 5 milligram and 1 tablet of clonazepam 0.25 mg. So this is pretty good and pretty okay for aborting an attack. So and then these drugs are given for a single dose only. We usually never repeat them. Drugs like sumatriptan and all do not have any effect in or any significant effect in relieving the vertigo of migraine related vertigo. They are very effective in headaches caused by migraine but not in vertiginous migraine. The next disease we would like to discuss is phobic postural vertigo. The presentation is very typical. There will be a feeling of instability, a fear of falling. There will be past history of some vertiginous disease like some previous attack of say positional vertigo or a vestibular neuritis, or some history of vertigo will be there which has actually scared the patient stiff, and the patient is now petrified or terrified of getting a fresh attack of giddiness. So these patients, they always feel that they are likely to fall. Possibly they will lose balance, possibly the giddiness will start again. So this is phobic postural vertigo. The clinical tests and investigations are usually normal, and it is usually aggravated by mental stress or by mental tension. So that is how we diagnose phobic postural vertigo. The medication used in phobic postural vertigo are specific therapy like SSRIs like escitalopram, which is a pretty safe medication if given in the dose of say 10 milligrams or 5 milligrams per day. Then paroxetine, then sertraline. These are pretty good drugs that can be given. These SSRIs are pretty safe if a reasonable dose is given, which is not too high. We sometimes combine it with benzodiazepines, and what is most important in these patients is counseling and psychotherapy. And this counseling and psychotherapy has to be done, of course, partly by you, by the doctor, but it is always prudent to have a professional psychologist who is trained in this to counsel the patient. They do a much better job than what we do. The next disease for specific therapies in our list is labyrinthitis. A patient of labyrinthitis will present to the doctor with the symptoms of vertigo with ear discharge, pain and deafness. The common causes are CSOM or some form of a viral labyrinthitis. Specific therapy for patients of labyrinthitis presenting with vertigo are antibiotics or antivirals, steroids and symptomatic therapy with vestibular sedatives and antiemetics. But whenever we are prescribing antiemetics or vestibular sedatives, we should always limit it to 1 to 3 days or a maximum of 3 to 5 days, preferably never beyond that. And if we cross 7 days, it is criminal. The next disease is Meniere's disease. A patient of Meniere's disease will present to the doctor with the symptoms of deafness, tinnitus and ear blockage, with vertigo, the duration of which would be anything from 15 minutes to about 12 hours. It will be episodic in nature, which means that there will be one attack today, another attack a few weeks later or a few months later, sometimes even a couple of years later. But in between the two attacks, the patient will be perfectly normal as regards the balance problem. There may be the deafness or the buzzing sound in the ear, that is tinnitus, or the ear blockage, but there will be no vestibular symptoms in between two consecutive attacks. That means the patient will not have any giddiness or any imbalance whatsoever in between two attacks. So this is very, very important. So this is called episodic vertigo. That means these are episodes, and in between two episodes the patient is perfectly normal. Meniere's disease is diagnosed by the very typical history as discussed. That means episodic attacks of vertigo with a persistent ear symptom, deafness or tinnitus or ear blockage that aggravates usually but not always during or prior to the attack of vertigo. So this is the typical picture of Meniere's disease. The investigations done for the confirmation of Meniere's disease are the audiological tests and the vestibular function tests. Basically, the audiological tests are more important for diagnosis of Meniere's disease than the vestibular function tests. In many patients, we find normal vestibular function, but there will be problems in the audiological tests. So, it is the audiological tests which are much more important than the vestibular function tests in diagnosing a patient of Meniere's disease. The audiological tests that are done in a patient of Meniere's disease are the pure tone audiometry with CC and tone decay. We would usually get a cochlear type of sensorineural deafness affecting mainly the lower frequencies or more markedly in the lower frequencies. Not always, but usually in the initial stages it is basically the lower frequencies that are involved. Later on the audiogram can become flat, and when the disease progresses much more, then it can be a moderately severe to severe deafness. Meniere's disease is diagnosed primarily by the audiological tests. The audiological tests will show a low frequency sensorineural deafness of cochlear type. That means the CC test, the ABLB test is expected to be positive, but the tone decay test will be negative. The glycerol test will usually be positive, and the other test that is done is the ECOG and the BERA test. The ECOG test would show the SP-AP ratio of more than 45%, and BERA would show more or less normal findings. That means the 1 to 3 interpeak latency would be within the normal range of 2.2 milliseconds. So these are the diagnostic criteria audiologically for diagnosis of Meniere's disease. So to summarize, the audiological test for diagnosis of Meniere's disease would be a low frequency sensorineural deafness of cochlear type, a ECOG showing a high SP-AP ratio of more than 45%, and normal findings in the BERA test. The other test that is done is the vestibular function tests, namely the video nystagmography, the video head impulse test, the cervical vamp and ocular vamp, the subjective visual vertical, and the craniocorpography test. These are the basic tests that are done. Some people add the dynamic visual acuity, the functional head impulse test, etc. But at least the video nystagmography, the ocular and cervical vamp, and the video head impulse test should essentially be done. Not uncommonly, patients of Meniere's disease show an abnormality in the caloric test VNG, but normal findings in the VHIT test. So this is one of the, it would not be correct to say that it is one of the criteria, but this is a not very uncommon finding in patients of Meniere's disease. The reasons for this are discussed in many texts, and we would not go into the detailed discussion on why the caloric test ENG VNG is often abnormal, whereas the VHIT of the lateral canals are normal in Meniere's disease. This is discussed in many texts here and there. Anybody who is interested can easily find out the different theories that have been suggested to explain this. So this is how Meniere's disease is diagnosed, basically by the audiological tests with support from the vestibular function tests. It would not be out of place to mention here that many patients of Meniere's disease would show normal findings in the vestibular function tests, but definitely abnormal findings in the audiological tests. A patient of vertigo who does not have any documentable evidence of hearing loss cannot be diagnosed as Meniere's disease. As Meniere's disease, the definition itself encompasses a documentable deafness. So that is extremely important. You may have a perfectly normal vestibular function, but audiological evidence of abnormality will always be there in patients of Meniere's disease. Now coming to the specific therapy of Meniere's disease. The specific therapy of Meniere's disease consists of diuretics, drugs like beta-histine, and symptomatic treatment with vestibular sedatives and antiemetics. Now coming to the diuretics. The diuretics that are usually prescribed in Meniere's disease are acetazolamide, spironolactone, furosemide, etc. There is a controversy on the use of beta-histine in Meniere's disease. Though beta-histine is promoted worldwide and very aggressively for the therapy of Meniere's disease, modern science does not have enough evidence to justify the use of beta-histine in Meniere's disease, whatever the companies that promote beta-histine can come and tell you. If you go into the books, you will find that there is not much evidence to show that beta-histine has got any positive role in the management of Meniere's disease. In fact, a lot of studies have been done. The Cochrane reviews have shown that there is no definitive evidence to establish the efficacy of beta-histine in the management of Meniere's disease. So, the question of use of beta-histine in Meniere's disease is definitely controversial. Now coming to the symptomatic treatment for Meniere's disease. See, in other diseases like say vestibular neuritis or so, we would prescribe the vestibular sedatives and antiemetics for 1 to 3 days, maximum 5 days. But in patients of Meniere's disease, we do not require to do so. We just have to abort that one particular attack which is taking place at that time. And we tell the patients that as soon as they find that the ear is becoming heavy, there is fullness and blockage of the ear, and the deafness has increased, and there is a feeling that the character of the tinnitus has changed, it has become louder, and just the patient has started feeling giddy. At that particular time, the vestibular sedatives have to be given. The medicines that are usually prescribed, see, different people will have different cocktails for aborting an attack of Meniere's disease. In my practice, I usually use 2 tablets of dimenhydrin at 50 milligrams and then ask the patient to suck 1 tablet of prochlorperazine 5 milligram and 1 tablet of clonazepam 0.25 milligram. So this usually suffices in aborting an attack of Meniere's disease. But sometimes what happens that the vomiting starts very early and the patient vomits out the medicine, and then we do not have any other option other than giving an injection of Stemetil followed by a 10 or a 25 milligram tablet of Phenergan. So that is how we abort an attack of Meniere's disease. This does not have to be repeated. So the vestibular sedative does not have to be repeated in a case of Meniere's disease. It is a one-time attack which will take place on one particular day, and on that particular day, as soon as the patient feels the impending attack, at that time itself the patient should take these abortive medicines. That means abortive medicines means the medicine that would abort the attack of vertigo in a patient of Meniere's disease. As we had been discussing, there are different studies which have shown that the drug betahistine, which is so widely promoted as the drug of choice in Meniere's disease, is actually nothing more than a placebo, and it is basically a hoax. That is what modern science tells us today. The Cochrane reviews also say the same thing, that is, there is not enough of definitive evidence to suggest that betahistine has got any positive role in the management of Meniere's disease. Now, I'll just show you one article which you are seeing in the screen now. It is titled Efficacy and Safety of Betahistine Treatment in Patients with Meniere's Disease. The primary results of a long-term, multicentric, double-blind, randomized, placebo-controlled dose-defining trial. It was published in the 2016 issue of the British Medical Journal, and this is the source. You can see it, and anybody, it's a free downloadable article, and anybody can download this article. Here it has been shown that according to the Cochrane review of betahistine for Meniere's disease or Meniere syndrome, there is insufficient evidence to say whether betahistine at all has any effect in Meniere's disease. In this particular study, patients were divided into 3 groups. One group was given just a placebo, another group was given a 48 milligram daily dose of betahistine, and another group was given 144 milligrams of betahistine per day continuously for 9 months, and these patients were monitored and again checked 3 months later to find out the efficacy of Meniere's disease. The study showed that there was no difference between the placebo and the 48 milligram daily doses and the 144 milligrams daily doses, which means that up to the dose of 144 milligrams of betahistine per day, it is nothing more than just a placebo. Though the pharmaceutical companies that market betahistine promote it as the panacea for all patients of vertigo and as the wonder drug for vertigo and for Meniere's disease, in effect what has been shown by science is that it is just a placebo and nothing more than a placebo. See, this study, as you are finding in this slide, show that the results do not give any clear evidence that patients have a relevant clinical reduction in the number of attacks after 9 months of treatment with betahistine at a daily dose of 48 milligram or 144 milligram compared with placebo, that is sham. So this is just a sham. And so we will have to be careful when prescribing betahistine in patients of Meniere's disease. The next disease in our list is vestibular seizures. The patients of vestibular seizures present with short repeated spells of vertigo, off and on at long intervals. Patients may be having numerous attacks per day, or sometimes the patient will have a few attacks, 1 or 2 attacks today, and again 6 to 8 months or 1 year nothing will happen, and again there will be a short attack of sudden severe vertigo. These are brief attacks without any provocation whatsoever. The specific drugs used for the treatment of vestibular seizures are antiepileptics like clonazepam, carbamazepine and sodium valproate. Of course, some doctors also use other antiepileptics, but then these are more or less safe drugs, and of course they have to be monitored well, but then these are the drugs that are usually used. The next disease for discussion is vestibular paroxysmia. The vestibular paroxysmia occurs due to a neurovascular conflict at the root entry zone of the 8th cranial nerve. The anterior inferior cerebellar artery or a branch of the anterior inferior cerebellar artery impinges on the 8th cranial nerve at the root entry zone, and it stimulates the vestibular nerve, due to which the patient gets repeated short attacks of vertigo. It is bound to occur numerous times daily. There is usually no auditory or central nervous system symptoms along with the brief spells of vertigo. The specific therapy for vestibular paroxysmia is clonazepam or carbamazepine. Carbamazepine works very well, but one has to be very careful when prescribing carbamazepine or oxcarbazine. Many a time, a lot of adverse effects can happen with the use of carbamazepine, and one should be very judicious when prescribing carbamazepine, be it for vestibular paroxysmia or for vestibular seizures. The next disease in our list for specific therapies is sensory ataxia or posterior column lesions. Sensory ataxia or posterior column lesions would cause the patient to present with imbalance, but there will be no vertigo whatsoever. There will be an unsteadiness which increases in darkness. This is the hallmark of sensory ataxia or posterior column lesions. It is diagnosed by the typical history, by NCV and SCCP, and by NCV and SCCP means nerve conduction velocity and the somatosensory evoked potential tests. There will be normal findings in all the vestibular function tests and normal findings in all the audiological tests. But the patient will come to you with instability and unsteadiness that is aggravated in darkness. So this is the hallmark. Therapy of sensory ataxia and posterior column lesions is pretty difficult because the drugs are basically methylcobalamin and gabapentin, but the main help that the patient gets is from very diligent physiotherapy. If the physiotherapy is done very well, then the patient does get some benefit, but this is not a very rewarding condition, and in spite of all forms of treatment, the patient does not usually return to normal. Now the question is, many a time we find that in patients of imbalance or in patients of sensory ataxia, unsteadiness, doctors very often prescribe the vestibular sedatives. This is extremely injudicious because a vestibular sedative would sedate the vestibular labyrinths and reduce the vestibular input to the central nervous system. Now, if these types of patients are already unsteady, and in these patients, if we further reduce the vestibular input to the brain, then we are actually increasing and aggravating the patient's unsteadiness, because now the brain is not getting the adequate input from the vestibular labyrinths by which it can maintain balance. And so, if the antivertigo drugs and vestibular sedatives are prescribed in a patient of unsteadiness due to any cause, due to say sensory ataxia, posterior column lesions, cerebellar disorders, or any form of ataxia, we are actually doing more harm to the patient rather than giving any benefit whatsoever to the patient. So we should be very careful, never ever, to prescribe any anti-vertigo drugs or vestibular sedatives in patients who present to the doctor with unsteadiness or imbalance. Specific therapy for bilateral vestibulopathy. A patient of bilateral vestibulopathy, which is usually but not always a sequelae of ototoxicity, would present with imbalance or unsteadiness, but there would be no rotating spinning sensation, no chakkar in the true sense of the word. There will be just the unsteadiness or the imbalance. One hallmark of these patients of bilateral vestibulopathy is oscillopsia. Oscillopsia means that when the patient will be walking, the entire visual surroundings will appear to be jumping, and this is very typical of bilateral vestibulopathy. If the patient comes and tells you that, sir, when I am walking, it appears to me that the surroundings are moving or jumping, the first diagnosis that should come to your mind is bilateral vestibulopathy. So the second question that we ask to the patient now is, did you ever have the aminoglycosides like gentamicin, amikacin, streptomycin injections? They will usually respond affirmatively. Of course, ototoxicity is not the only cause of bilateral vestibulopathy. We do get a number of patients of meningitis who present to us with bilateral vestibulopathy. We get patients of encephalitis who present to us with bilateral vestibulopathy. So bilateral vestibulopathy is not very uncommon but not so common also. So the patient of bilateral vestibulopathy, which is usually due to ototoxicity, would present to the doctor with imbalance, unsteadiness, but there would be no rotating spinning sensation whatsoever. There would be oscillopsia, which we have already discussed, and there will be usually no deafness along with it. Of course, if it is due to ototoxicity, some bilateral high frequency sensorineural deafness may be there. If it is due to encephalitis or meningitis, then again deafness may be there, and deafness due to meningitis is usually pretty severe, but not always. Ototoxicity is diagnosed by a pure tone audiometry, which would usually but not always show a bilateral high frequency sensorineural deafness. The vestibular function tests, especially the VNG and the video head impulse test, would show poor response. The cervical and ocular VEM may or may not be positive. That means quite often we find that in patients of bilateral vestibulopathy, it is only the semicircular canals that have been affected, but the otolith organs have been spared, and so normal findings in the VEM test, either CVEM or OVEM, does not rule out the diagnosis of bilateral vestibulopathy. In posturography, there will be instability on eye closure. So these are the diagnostic features of bilateral vestibulopathy. Specific therapy for bilateral vestibulopathy is primarily stoppage of the drug if it has already not been stopped, and the vestibular exercises. Not that they are extremely effective, but whatever benefit can be obtained, we should try to get it, and it is only the vestibular physiotherapy that helps in these patients. Other the benefit that the patient gets from the diligent vestibular physiotherapy in a patient of bilateral vestibulopathy is also not very much. So some improvement is not unexpected, but the results are not very rewarding. The next in our list is central vertigo. Patients of central vertigo would present with not much of a rotating spinning sensation. That means the spinning will not be there, but these patients will have quite a bit of imbalance or unsteadiness. There will be repeated falls, there will be disorientation, and usually no deafness whatsoever. Whenever we get a patient like this, we should suspect of a central disorder. It can also be due to a bilateral vestibulopathy, it can be due to something like sensory ataxia, but these are the differential diagnoses in patients of imbalance or unsteadiness. So how do we diagnose a central disorder? It is diagnosed by abnormalities in the oculomotor tests while doing the VNG. In posturography, there will be evidence of gross instability. The VHIT, the video head impulse test, would usually be normal, and the VEM tests would also be normal. Abnormalities in the VEM test would suggest that it is not a case of central vertigo and it is an otolith disorder, because quite often otolith disorder patients also present with similar findings, that is just instability without any rotating spinning sensation. So the differential diagnosis in a patient presenting with instability or unsteadiness without any rotating spinning sensation are central vertigo, sensory ataxia, bilateral vestibulopathy, and otolith disorders. Okay, so that brings us to the end of the different diseases that and the specific therapy for the different diseases that causes the patient to present with either vertigo or imbalance to the doctor.